I see people are joining. Welcome to the Mailman Center Grand Rounds for 2025. This is our monthly series where we invite speakers, usually coordinated by our interprofessional collaboratives, to share their innovative work in improving lives for children and adults with disabilities. Last month, we had Dr. Danny Armstrong, the director of the Mailman Center. He gave an overview of the Mailman Center achievements for the past year. And if you missed that talk, no worries. You can go to the Mailman Center YouTube website and check out the talk. We typically start each of our years featuring high impact, cutting edge speakers, usually in October and November. And then in January, our interprofessional collaboratives will invite speakers to come to speak to us for our grand rounds. Over the summer, I serendipitously ran into Dr. Lee Sanders at the Miami Head Start Health Summit, and he was talking to me about his groundbreaking work developing novel artificial intelligence tools or using novel artificial intelligence tools to improve care for children with complex medical conditions. And I immediately thought that we needed to invite him to our Mailman Center Grand Rounds for October. So I thank Dr. Sanders in advance for that. He is from Stanford University, where he is a professor of pediatrics, and he is the division chief for general pediatrics. But he is no stranger to the Mailman Center Department of Pediatrics. He was previously, I have to say this, he was previously the course director for the pediatric advocacy training. And in fact, our leadership education and neurodevelopmental leadership and systems change advocacy curriculum is really based on his early work in directing that advocacy for the pediatric residents. But today he's going to talk to us about AI, health literacy, reducing disparities in health and education, which is some work that he's been doing over the past 3 decades, although it doesn't look like he's been working that long. His work continues to drive innovation and impact in these areas. And without further ado, I am going to turn it over to Dr. Sanders. So thank you very much for coming and speaking with us today.
Thank you so much, Michelle. I hope everybody can hear me and see me. That was a very generous introduction. I'm sorry to disappoint everybody after that generous introduction, but I'll try to live up to it. It's great to be back with all of you, if remotely. I try to get back as often as possible. Not only am I of the University of Miami, but also of Florida, where my entire extended family lives. So yeah, I guess I should preface this by saying when I left Miami, it feels like yesterday, but it was 13 years ago, to come out back to Stanford, back to Silicon Valley. People asked me, why are you doing this? And I remember saying to some people, maybe Valerie, you as well, I said, well, I kind of have this vision that maybe I could turn 1% of the minds and 1% of the money in Silicon Valley to the needs of poor kids. I'm still not sure that I've exceeded that threshold, but I'm still working on it, and was meeting with folks yesterday about that. And so what I'm going to share with you is just a bit of a story of that journey, anchored in some of the research I've been doing, framing it in a way that I hope is useful for all of you. And at the end, really, this should be a conversation. I would love for you to challenge me, talk to me about anything that maybe inspired you, made you think differently at the end. But first, if you guys can see the slides here, I need to always start with some disclosures. So there's the standard disclosures. A lot of the research that I'll be presenting is based on research funded by a number of agencies, including National Institutes of Health, CDC, FDA, PCORI, which is the Patient-Centered Outcomes Research Institute. And I have consulted and am consulting for a number of companies. Actually, Stanford encourages us to do that. Including AI companies that concern themselves with health. One of them is Metaloop, that's creating a whole new platform to make grant writing easier, analytics easier, so look out for that. And Cognoa, that works on improving care for kids with autism. But with all that, I feel very privileged to have worked with all of you, and very curious and very grateful to many colleagues. I tried to put as many names here as possible. You can see they start getting cut off at the bottom, but many of them joining us here. Danny Armstrong, thank you for joining us and all of your leadership at the U. Ruby Natale, who I'm still publishing with. Jeff Brosco, who I'm still meeting with, and is actually we'll talk about later, providing a challenge to our design school lab. Alan Delameter, still doing research with. Valerie, great to see you. Michelle, thanks for welcoming me. And Lisa Blair, still working with Reach Out and Read and early childhood efforts across the country, including in Florida. Lots of other people there, so I'm very thankful too. And there's also another part of my story. So, I started off in training as a physician, got some basic training as a scientist in epidemiology. And I've been a leader, currently directing the Division of General Pediatrics out here. But something happened to me about 16, now 17 months ago that has actually reframed my view of everything I'm going to be talking about. And that is that I woke up from an endoscopy suite for a pretty standard screening and was told that I had an esophageal tumor and that I had about a 50% chance of living the next 2 years. I can have my whole talk on what that journey was like, but I will tell you two things. First of all, obviously, I'm here with you. I'm healthy. I'm in remission. And my journey as a patient was not all that straightforward. I was a VIP patient. I was being treated at the place that trained me. I was on administration here. I'm a physician. I'm a white male. All those things that make me privileged. But I still found myself mistreated at times. And more importantly, I was looking left and looking right and seeing the mistreatment that occurred after 30 years of doing research in health literacy and the patient experience that were still occurring to patients all around me. And it was very, very concerning to me. And it makes much of what I'm about to present to you very urgent and real and morally clear that we need to address. So that's my experience as a patient, but I'll bring it back to an exam room at across the way, right there at University of Miami. This is me examining a patient. I've changed her name, but the story remains the same. And the other thing that's changed is you can see I have more gray hair now than I have in this photo. So Aria is a 4-year-old girl with preterm birth, intellectual disability, chronic lung disease, and feeding tube dependence. She's on 4 chronic medications. In her young life, she's already dependent on the care of 12 different subspecialists and has been seen across 3 health systems. Her mother and sister have a chronic disease, and she lives in a small 1-bedroom apartment with her family and her aunt, and her mother with limited formal education and limited English proficiency. Or as we like to say, in the practice there at UM or out here, our average patient. Another way of viewing this, rather than from the medical perspective, is from the family's perspective. This is a care map drawn not by actually Aria's family, Aria's mother, but another mother in one of the national parent networks, Kristen Lind. So she's credited there. And you can see at the center is, of course, the child and the family. And I like to remind everybody, and maybe this crowd doesn't need to be reminded of this, but certainly many of my medical colleagues need to be reminded that from the perspective of a family, what a family needs to navigate every week is not just the healthcare system pictured here in the lower left-hand corner in blue, but all of these other parts of their world, developmental assessments, school, advocacy programs, recreation and community, and personal support services. And having that as a picture, previously as a care provider and as a scientist, and now as a patient myself, really reframes my view of the essential question that keeps me going day to day, which is what kind of system do we need to meet everyone's health needs? Everyone in that exam room. So always before I was thinking about the patient and the parent and the sibling, now I actually think about the healthcare provider as well. What kind of system do we need? So here are the 3 things I want to go over for you. And if you're wondering what those 3 marks on there, I don't know. We'll take that as there's these little red marks. somebody is telling us something, but hopefully that's not distracting for you. These are the three things I want to go over and hopefully discuss with you my perspectives on very humbly and get your feedback. One is to frame key challenges in child and adolescent behavioral health. Second is to review the evidence base for AI or artificial intelligence tools to support that health. And finally, to explore health literacy, which I've been researching now for nearly 30 years within a human-centered design framework as a way to further develop these tools and really bring in the voices of the people being served. So first, let's talk about the key challenges. Here's a map from above, a Google map, of course, because I'm in the land of Google, of where I'm sitting right now. So this is Stanford and the surrounding areas. And that red line is meant to be a red line for a reason. You guys know about redlining. That's East Palo Alto. You can even see from above fewer trees in East Palo Alto. This is to the east of us. This is a traditionally underserved and under-resourced community compared to some of the most wealthy communities in the country, which are just on the other side, literally, of the train tracks here. So you've seen that before, and you may or may not be aware of this, but there's a real disparity in life expectancy, depending on where a child lives. Now, we have, as you guys do, a birthing hospital. All of the children in this region, or most of them, are born at Packard Children's Hospital. I get to take care of them. But the child's life expectancy is dependent not on where they're born, but where they live when they go home. So a child's life expectancy, if they go home from Stanford Children's Hospital and they're living in this area in the lower left-hand corner, is 80 years. And if they go home to a home in East Palo Alto, it's nearly 20 years shorter. And there are a lot of reasons for this. And I'm not going to give you a lot of the talks you've heard before. I'll give you my own a slightly different, I think, perspective on the mechanisms behind that. But this is true across the country. You can go to the Robert Wood Johnson Foundation's website and find this for any area that you live or that you grew up in. But of course, here's the area that you guys live in. And I thought about this even when I was practicing there at University of Miami. So we have the practice, we have Jackson Memorial Hospital sort of up in this upper right-hand corner, and we have the rest of the University of Miami, the main campus, down here in Coral Gables in the lower left-hand corner, and similar disparities, right? So the life expectancy of a child who goes home, an infant that goes home from the hospital to live closer to the medical campus, Overtown, Liberty City up there, is quite a bit lower, 68 years, than the 86 years life expectancy if they go home to a home here in the lower left-hand corner. So these are geographic barriers within or differences within the United States. There are also global disparities that I work on with colleagues here at Stanford. And this, you've probably seen different versions of this before, but this really comes from the World Bank. We know that we spend more per person in the United States on healthcare and direct healthcare services than anywhere else in the world, and we get less out of it. So despite being on the right-hand side, the United States, over $8,000 per person per year, our life expectancy is far lower than many countries pictured here that spend much less per person per year. Similar data, by the way, if you look at other outcomes like chronic disease or child mortality. So it's for this reason that some people have said that the geocode, I use this globally because I was just presenting this in Europe, or the zip code is more important than your genetic code for determining your health outcomes. So in large epidemiologic studies, it's still true that social factors, physical environment, social context, individual behavior, we'll be talking a lot about behavior coming up, is more closely correlated with mortality, life expectancy, adult onset of chronic disease than any biologic factors. So all the omics, genomics, metabolomics, microbiomics, and certainly than the health technology that we have access to. This is very true in sort of a very scattershot, not scattershot, but observational epidemiologic sense. But as I've come to learn more from my colleagues out here and doing some research, this is somewhat too simple of a picture. And it's very important not really to get away from the term determinants, right? These social factors are not really determinants. What really does determine our health outcomes or our health inequities? So let's think about the definition of health inequity that comes from the World Health Organization. This is what it is. It's a systematic, preventable difference in the health status of people based on that person's social, ethnic, racial, geographic, or economic status, right? This is the definition that we have. It's systematic and preventable based on where you live, maybe what skin color you have, or what your income is. These are things that we feel are preventable. Why? What's really going on? Well, what I'm about to show you is a very simple, it's a 3-part model, but I'm going to go through it slowly because, and if people have a chance to write this down, you can look. This is not my work. This is the work of my mentor, Paul Wise. There are actually 3 ingredients of any health inequity, and we always intuit the first part. So when we think about inequities, we always think about poor access, right? Poor access must drive all of the inequities that we see. But it's not that simple. There are actually 2 more critical ingredients, and you can apply this to any inequity in healthcare. And it's poor access for a high-risk population. That's the population that's high risk for whatever outcome we're concerned about. 2, a highly efficacious technology. And the reason why I'm going slow on this is because a lot of times, even those of us who are researchers, public health researchers, or advocates, often forget these 2 other ingredients at our peril. And we wind up going down rabbit holes that are not necessarily useful to the populations being served. I'll give you some examples of this in a second, but remember, it's poor access for a high-risk population to a highly efficacious technology. That's what causes a serious health inequity. So I'm going to give you some general ways in which this fits into what I think are the major challenges and barriers to child and adolescent health. One is epidemiology. We know that there's a high-risk population. These are the 15 to 20% of children who have special healthcare needs. They often, or their parents often, report, up to a third of them, and it's now 10 to 20, 30%, depending on where you live, report not having their healthcare needs met, even though they have these special needs. We think that some of that requires more coordinated care, but more coordinated care, better access to what? Well, efficacious technology that works. I can't go through all of these, but you guys are expert in this. For a particular condition, there might be variable efficacy for, let's say, speech therapy under the age of 2, maybe lower efficacy, but speech therapy between 2 and 5 might be highly efficacious. Or to a lot of the work that Michelle is talking about, there might be a certain type of assistive communication device that's highly efficacious, but there might be another type that's not very efficacious, and the subtleties there really matter. Around policy, we know we'll be talking about health literacy. 1 in 3 parents, 1 in 3 adults in the US have limited health literacy. More than 80% of the information we provide is not understandable, and it requires better human-centered design. So we're going to be talking more about that later. And then we need to recognize the imprint of social well-being around this. Still in the US, 1 in 4 children live in the chronic stress of poverty. We got that down to nearly 1 in 6 children during the pandemic because of public policy changes, but it's floating back to 1 in 4 children living in poverty and not getting their behavioral needs met. So before I go on, I'll just mention one other example of how always new technology increases a disparity. This happened with surfactant. For those of you who were earlier in training, you might not have been there when I was in training, and many other folks. We had this great new technology to improve the survivability of preterm infants, and it widened a disparity. We already know that there are black-white disparities in outcomes, mortality, preterm birth survival, and so forth. It widened that black-white disparity for about 5 years before it got better. That's another example of a highly efficacious technology, just because it's efficacious, kind of causing a disparity. Why? Because despite people's aspirations, otherwise, it went to the wealthier hospitals, the more equipped hospitals, maybe some of the academic medical centers before some of the larger places that really needed it. I could go on and on. There are other examples of this, but I want to move into what Michelle asked me to talk about, is what I'm learning about AI tools. AI is everywhere. It really is changing what we're doing. I don't know how many of you are using it. I was in our federally qualified health center yesterday using AI to help the medical students expand their differential diagnosis for a couple presenting conditions. So we're using AI, we're using large language models, particularly everywhere. Well, what's the evidence base that we know for digital tools to not just support behavioral health, but to address some of these inequities that I talked about? Well, for you guys, as well as a meeting, I just went to an international meeting in Europe. I did a scoping review for you of systematic reviews, trying to document both digital health and the newer AI tools and how they're really supporting child behavioral health with a lens toward addressing inequities. And these are roughly the three large areas where AI tools seem to be most promising, and some particular examples of each and in each category. And I'll go into these in greater depth in a moment. So under health behavior coaching, think chronic care coordination, and also supports for chronic disease self-management, particularly around individual diseases. Type 1 diabetes always seems to be out ahead in this, but also some other chronic conditions. Parenting, for what we know of parenting, so parent coaching. Obesity prevention and treatment tools are using a lot of AI. The second area is in screening. A lot of what we do, obviously, in primary care is around child development screening. I think that's going to be somewhat upended, but really leveraging all the work that's gone before this, but also screening for adolescent depression and anxiety. And then finally, mental and behavioral health treatment. There's been a lot of work over the past really 10 years to develop apps that support cognitive behavioral therapy for the treatment of adolescent anxiety and depression, and you're going to see them infused with a lot more personalized AI attributes over the next few years, and actually you're going to see companies marketing that. Same thing for ADHD. There's a lot of work. Actually, one of my colleagues here is doing work using natural language processing to look at the quality of ADHD care, our ability to surveil for medication side effects, and the efficacy of both medication and behavioral therapy for ADHD. And finally, in autism, there's been so much attention to this, so much funding to try to look at the essential causes of autism. But when it comes to both the early diagnosis of autism spectrum disorder and also developing techniques that augment ABA and other social skills training for kids with autism, that seems to be very promising. We're going to talk a little bit about where the human is in the loop. I want to make sure that before I go further into talking about some of these AI tools, Fei Li, who is a mentor of mine here and headed or co-chaired Google X for some time, has written a number of articles about this in a book. And she emphasizes that any good AI does not replace a human. Any good AI simply augments what we do to make it more efficient and more effective. So I'm going to give you some examples of some of these evidence-based tools. Largely through my own work, but I'll be alluding to others. And I want to hear, by the way, about what all the work that's going on there at Miami, at Mailman, and so forth. This is a tool that I actually developed with a computer scientist who is Barbara Gross, who's one of the progenitors, the creators of natural language processing. She's now emeritus at Harvard. She's a brilliant computer science researcher. And it's a platform to aid in chronic care coordination called Goalkeeper, and we developed it with some NIH funding. As you can see, it doesn't look too flashy, but it allows parent and a provider to ask about their wishes and worries, or the parent's wishes and worries for that child, and to set very specific goals based on goals that other patients like me or parents like me might set in the exam room, and to track them over time. I can go into more about this tool, but what I want to point out was the magic of working with Barbara, or Dr. Gross. Remember, she's a computer scientist. I thought she'd be there and help us build this whiz-bang platform, and it was pretty good. We developed it. But she did the really hard qualitative work, and she came into the classroom, and what she really noticed was what was going on at the human level. She, to me, is my model for a great computer science researcher. And what she saw was that families were saying, we have real goals for our children. They are non-medical, and nobody is listening to us. We write them down. We put them down, in physical therapy planning notes. We we put them down on paper before we see the primary care provider, and we put a lot of effort in this, and no one's paying attention to this. So she really paid attention to this. She forced this, and I can talk about the data in a second from this group, but I'm going to talk about the data of one of me. So all of a sudden, you know, I was burning out like a lot of the rest of you during COVID, and I started using this tool. And instead of what I was doing before, with every family that came in, I would say to the parent at somewhere in the visit, I would say, I just want to take a break for a second. I want you to think as far as you can about the future of your child or your child's health. And I really want to know what you're most worried about and what you wish for. And what happened was like magic. Even as I'm telling this, I'm getting a little choked up. Almost every time the parent started to cry, usually, and I started to cry a little bit. And we went into why we were really there. And a good AI tool will do that. A good AI tool will not replace this. And so we're working on developing this tool, but you know, in some ways, you know, so I'll tell you some of our preliminary data. We did run a pilot trial of this. We did find that it improved outcomes in goal setting and shared mental models. I won't go through a lot of this, but you know, whenever you see cross lines in a control trial, that's a good thing. It means that the intervention group was performing a little bit better. This is a pilot intervention that we're still developing. And it might not be Goalkeeper itself, but I do think that there's a lot of promise for these tools if they really bring dyads together, human interaction, relational health between a provider and a parent, or a provider and a patient better. Here's another project that you all at Miami have been involved in, because I started getting involved in it when I was at Miami, called Greenlight, where we took on a wholly different problem, which is how do you really do obesity prevention starting in early infancy? And this is a totally different approach to preventive care. Parents are often coming in, they want to get a little advice, they want to get their kids vaccines, they want to get out of there. We really thought that we could do something to address one of the signal child onset conditions that predicts adult disease, right? The big child antecedent of adult cardiovascular disease is obesity, really obesity in adolescence, but there's some predictors in early childhood, namely rapid infant weight gain. So we developed these booklets with families in Miami and Chapel Hill and Nashville and New York City, from different backgrounds, different cultural backgrounds, and particularly with low literacy and limited English proficiency. So we developed these written initially in English and Spanish. We actually now have them in Mandarin Chinese as well, and starting to develop them in Arabic. But they really address evidence-based practices that we expect parents to pick up in early childhood, things like not using sugary drinks and other healthy eating habits, as well as physical activities. We use very colorful renditions of this, and also kind of a traffic light. That's where Greenlight comes from, motif. So red, yellow, and green guides. We have goal setting. I just talked about goal keeping, goal setting that's reinforced in the exam room using these tools. So we developed these from birth to 18 months. We had supplemental booklets. They were professionally produced. We trained medical providers, pediatric providers to deliver them, and we had a block randomized control trial to look at this. We published this in Pediatrics a few years ago, and it's a mixed bag what we found. We did find that it improved and reduced rapid infant weight gain really through 15 to 18 months. But by 24 months, which was our primary outcome that we announced in clinicaltrial.gov, it was a null study. So no differences between the intervention group and the control group at 24 months. So disappointing, but still it led us to think, well, what was going on in those first 12 months where we thought we were getting some movement? And we realized, oh, well, we have like 6 or 7 visits between birth and 15 months. But then those primary care visits fall off. We don't have as much interaction. And so we developed and built on top of a pre-existing platform called IOTA that was developed at Duke University, a digital AI-driven enhancement to Goalkeeper. And we were able to randomize it with funding from the Patient-Centered Outcomes Research Institute at the individual level. So we get a lot more statistical power into this in another iteration of Greenlight, where everybody receive those same booklets, all the providers receive the training, but a random half of families got this text messaging tool that sent them to a dashboard. You can see and see some of the screenshots of what it might look like from a parent's point of view, in the language of their choice, and also the goals of their choice. So very interactive text messaging, AI personalization. And I wish I could show you the results from this, but they are currently embargoed. I will tell you which journal they're embargoed in, because I want you to read this. It's going to come out right after Election Day. It's going to be in JAMA. They're really interesting results, and they suggest that this is probably the right way to go, not just for this intervention, green light, but for other interventions in primary care where we're really concerned about supporting healthy behavior change. So that's a couple stories from sort of goal concordant care where I think AI tools are going to be really helpful. Let me take a break to talk a little bit about the acceptability of AI tools in child behavioral health. I work at a place called the Clinical Excellence Research Center, and they do all kinds of work around reducing costs, but also leveraging new AI tools. And we're able to conduct a national survey of parents around the country using Amazon Turk, and discovered something about these acceptability of AI tools. As I mentioned before, nobody out there pretty much wants any AI tools that do not have humans in the loop, that do not allow us to control the tool and also allow us to reach out to a human when we need to. So that's consistent around a lot of studies, including one, this is by Jill Glassman that I mentioned, where he picked up on some of these concerns about privacy and security. What facilitates that are video-enabled information with limited text. So that's some of the health literacy lessons that I'll talk about in a second. The ability to personalize whatever we're working with, the ability to connect with other humans. So that could be a human coach or another human like me, and options to receive text message reminders at the cadence, at the frequency that I want. So rather than, push, as we do sometimes on our cell phone, delete the junk or something like that, that allows us to say, well, maybe get back to me every month instead of every day, and I'll work with this. So that's what we've learned about this. This is a really poor schematic, but it's from the publication that just came out this year that Jill Glassman was the lead author on, and that we did this national survey of several hundred parents. Actually, it turned out one of them, our first survey was before COVID, so we repeated it during COVID, and it was actually pretty consistent, even for parents who were stuck at home with their children, that it's both half empty and half full. So about 2/3 of parents say they are very willing to use a computer-assisted coach or an AI-assisted coach to help care for their child, and also to help them control the way in which they're using technology. So fighting fire with fire. We know that these devices are getting in the way of our parenting. So would they be acceptable? Well, about 2/3 of them would do that. And we looked at what were the barriers in technology acceptance. And that's where these issues of privacy, security, having a human in the loop were very instructive to some of the tools that we're building. Here's one of the tools that we're building out of this group. This is, because I get to work at Stanford University, where we have the Human-Centered Artificial Intelligence Initiative with some internal funding. We developed a tool that for those here, Ruby, I don't know if you do this. I know a lot of other folks do this. Is a lot of child development research is based on these videos of parents interacting with children, right? And they're coded by usually undergraduates. I know my daughter is an undergraduate doing this right now, right? They're laboriously coding these videos time after time. Well, we developed a tool called Harmony, which uses computer vision algorithms and audio algorithms to automate the coding of these videos. They're called mesh pose estimations. It's deep computer science. It's not what we usually think of right now when we think about AI, but we're able to automate this coding and save, you can see 161 savings in that computer time versus human coding time. There's still a human in the loop to make sure that we're not missing anything, but it really allows us to do this. We're able to track all types of child caregiver interaction, verbal and motor, and even visual. We're able to get to things like shared attention, touching, not touching, all these sorts of things, ambulating, and the pose of the infant. Really exciting stuff. I think it's, for now, we think it's going to fundamentally change a lot of the aspects of child development research, and maybe even parent-child interaction therapies as things unfold. So we have a group working on that. And the last example I'm just going to pick here is not actually from my own work, but a close colleague named Dennis Wall, who for now nearly 15 years, first at Harvard, now at Stanford, has been developing really creative technology to improve early autism detection and early autism treatment. It was very affected, as by so many of us, by he's a brilliant computer scientist, but by his personal experience with a member of his family who had autism. So without going through a lot of this, he's created tools that allow you to download a video from YouTube or your phone and can do some of the pose estimation we just talked about and pick up on kids with lack of shared attention or echolalic speech, that sort of thing for diagnosis. The really exciting stuff is in the intervention side. He has this great game to allow children with at certain points in the autism spectrum to better recognize a series of emotions. And he's even migrated that tool from a cell phone over to Google Glass. You might remember Google Glass. It's nobody uses it anymore, but he's using it actually in the clinic to sort of give these kids what they say are superpowers. A lot of the kids say, well, I feel like I have emotional superpowers after using this. So I think there's a lot of hope and promise in those tools. So with the last part of this talk, I want to talk about what we can all do together, and I think health literacy is a grounds that's very approachable, whether you're coming at this from a clinician's perspective, a community-based perspective, you're working in a daycare center, a clinic, or residency, and that is how to use health literacy within a design framework to develop or inform some of these AI tools that are supporting behavioral health. This data I referenced before comes from national assessments of U.S. adult literacy skills that come out of the U.S. Department of Education every few years. More than a third, or 90 million U.S. adults, have below basic or basic literacy skills. It's about that same number, a little bit lower, about 32% for parents of young children. Here are examples of things that are difficult for people with below basic or basic literacy to do: understand an appointment slip, dose out over-the-counter medication, interpret a growth chart, determine when a child's next vaccine is due, based on the materials we give out. So we assume that all this information that we're giving out in the conduct of daily care is understandable, but we really need to be a little more sensitive to the fact that up to a third of the people we give this to, it's a little bit of a struggle for them to use it, at least in the current state. So what is that current state? That most of the information in health websites, insurance enrollment forms, medication labels, and so forth is written at a level that's too difficult for people to understand. My colleague, Deborah Roeder at Johns Hopkins, calls this public health malpractice. So I have to put that in every presentation I give to wake people up, at least the physicians in the room, when I'm talking about that, because we wouldn't do this with any medication directly, something that people simply couldn't use. That wouldn't be right. And it has real impact. This comes from a systematic review I did many years ago, where I've been adding to it over time. It's actually time for me and a trainee, if one is out there, to redo. But it looks like low parent health literacy or low adult health literacy is associated with a number of child health outcomes. Generally, those that are particularly behaviorally embedded or subject to a great deal of parental discretion. So these are things in the upper left, like breastfeeding, obesogenic behaviors, injury risk behaviors, and tobacco use in adolescence, maternal and child health outcomes like maternal depression and worse control of and self-management of chronic illness, as well as uninsurance and decreased usual source of care. So it's in this conflict where there's actually an opportunity for design and more responsible design of AI systems. So this conflict between the skills of the populace and the complexity of the information that we have offers us an opportunity to better design actionable information for real people at real points of care. And I spend a lot of my time doing this in the lab, and also, in some of my work with consulting. So how can we do this? How can you guys begin to do this tomorrow? Well, first is to train ourselves and train providers in clear communication. One thing that is heartening to me is to see that most medical schools and nursing skills are doing this. Many hospitals are doing this on a regular basis. teaching universal communication principles. There are, if you're curious about them, there's EACH is the acronym of an international body that provides these training courses. We can talk a little bit more in the Q&A if people are interested. I simplify those clear communication principles into listening more carefully, simplifying the words that we use, and learning how to use teach back in an efficient way, an effective way in our daily practice. And then the final piece that I'll be talking about and telling you about some of my experience out here about is co-design, co-designing with people with limited language or literacy skills, everything that we do. And that's an easy word to put on a slide, co-design. It's not so easy to do in practice, but once you get started in doing it, it's so fulfilling and so creative that it's just fun to do and something that morally we should be doing, I think, to address the underlying inequities that we talked about. So I have the opportunity of teaching at a place at Stanford called the Hasso-Plattner Institute of Design, or the D School, instead of the B School, which is the business school. It's the D School. And I offer this challenge once a year to our students. And I should mention that our students come in two sets. The main students are Stanford students, undergrads and graduate students. So right now I have 15 of those students. They are undergraduate majors in computer science and symbolic systems. Don't ask me what that is. They try to teach me every year, trying to figure that out. Human biology, other thing, and also graduate students from the graduate school of business and engineering. But also patients. We consider our patients and caregivers our co-students. We ask them to apply we give them and teach them human-centered design skills and ask them to craft a service or system that improves access to an efficacious health technology for everyone at risk, using that model I talked about before. And every year we have a different challenge that's usually offered by an external partner. It might be a health delivery system, a hospital, a clinic, health insurer. This year it comes from the Maternal and Child Health Bureau that's part of HRSA. Why? Because your own Jeff Brosco is now directing the Division for Children with Special Healthcare Needs. And he was telling me, well, wouldn't it be great if? And I said, well, why don't you offer that challenge to our students? And we're going to see, we're in the middle of the quarter, we're going to see what they come up with. So if, at the end, I'll tell you what that challenge is. But over the years of doing this, my students who have no training in healthcare, but really good training in design, and the parents who come in and really get vulnerable and offer their stories, together have come up with some brilliant ideas. So they've actually fueled some of the additions to Greenlight and Reach Out and Read that I've been working on. But I want to mention a few of the other ones that are up here. Up at the top, first year I taught the class, they came up with Village, which is a wedding registry for post-NICU support. They imagined repurposing TaskRabbit for helping parents that come out of the NICU, particularly in low-income areas. We had a virtual pharmacist for adults with chronic illness that came out of this. My favorite and most elegant design, though, was this. You can kind of see that tag there, that ID tag. I don't know if you can see it very well, but it says family on it. And this came up from one of our early design students. And one thing that he noticed, because a good designer doesn't just listen, but they notice, they observe, was that I would be running to class a lot of times, and it would always have my hospital badge on. It was when it, was clicked around, made all this noise. But it gave me a certain sense of authority right in the hospital. He said, well, what if we give that kind of authority to parents and families, instead of calling them frequent flyers, which is what if we used a badge to elevate the status of parents who are really expert in the care of their own children? So that instead of them being demoralized by, someone half their age, sometimes asking them about, what their child, telling them what their child needs when they know better, a parent can earn that badge. It can be signed off, it needs to be earned, signed off by, 2 physicians, let's say, and 2 nurses at the facility. But that says that this family really knows what they're talking about. They can be brought on as a co-designer of that healthcare team right there, right then, in the emergency room, in the hospital wards, wherever. And by the way, also give them 40% off at the hospital cafeteria instead of 10% off, because they know what they're doing and they're here a lot. So, I mean, it's elegant designs like this that can come out of really good co-design. And we take our students and we take our families through really the vulnerability of sharing everything, sharing the positive stories. We're coming up on Halloween costumes, families come in, they share this, they told me I could share these photos. We take them to the clinic, we show them the reach out and read books. I know they're falling apart. We also show them the boards where, you're always taping up and duct taping the system together, and the fax machine in the lower right-hand corner, and how much our patients are still in the 21st century dependent on fax machines, even though they're trying to design AI solutions. And so out of all of this, we create all these great designs, but unfortunately the quarter ends, and some of these great solutions never see the light of day. They never come into the clinic. They never get funding. And so we're now imagining a design studio where we're actually going to bring in industry partners, people with money and people with places where these solutions can be iterated, to provide an open platform for the development of AI-driven solutions that serve the public health by addressing these health inequities. If you're interested in this at all, interested in learning more, say so now, follow up with me, because we don't really imagine this as being a Stanford thing for long. We really want it to be, as we kind of test it out and see if it can work, we want it to be global and national. There are a lot of other health design labs going on like this around the country. So I'm just going to close and try to summarize some of the things that I've learned from doing this work. One is that to really address health inequities, as I said, we need to not only improve access, but think about the highest risk communities that we're improving that access for, and the most efficacious technologies that we're providing to them. Second is that we need to think hard about how to co-design with families from these high-risk communities using a health literacy lens. And through all of this, and I mentioned my own personal experience, but I used this word even before I got a cancer diagnosis, to practice humility. Where I'm not here flying in from Stanford telling you I have all the ideas. I'm just telling you that I'm more curious than ever and have a renewed sense of urgency more than ever to work with you, to learn with you and everybody about how to address these issues. We need to. Children are counting on us, parents are counting on us, communities are counting on us. So with that, I'll just paraphrase again one of my mentors to say that, we see bad health outcomes, sadly, for children around us, and any bad health outcome, particularly for a child, is a tragedy. But back to the definition of health inequities, any preventable bad outcome is something else. It's unjust. And that's where the urgency comes in. And that's why I thank you for your attention. That's why I thank you for your colleagueship, your inspiration, and I welcome any questions, any ideas, any challenges to that. So I'll stop there. And Michelle, I don't know if there are any questions that have floated in with the chat, but as I said, I want to certainly facilitate a conversation around this.
Thank you very much, Dr. Sanders. The only request that we've had so far in the chat is if you would be willing to share your slides. So if so, you can send them to us and we can forward them along. We did record the session, so it will be available on our YouTube channel. If people have questions, they can put them in the chat, or feel free to raise your hand and ask your question.
Well, Lee, I'm going to have a hard time raising my hand, but I'll wag at you. It's so good to see you. And I think for us, Michelle may have shared with you, we're in the middle of a strategic planning process for the Mailman Center. And one of the three prime priorities in that strategic planning process is to do exactly what you've talked about today, to really look at the use of technology to improve access to behavioral and developmental services, not only to use what's being developed, but to contribute to the development of new technologies that apply that. We've certainly, you and I've had conversations about this area back before we even had the technology to support it. So it's wonderful to see what you've imagined and the alignment with what we're trying to do in our next 10 years here at Mailman is actually, well, not surprising. But yeah. Thank you so much for sharing and continuing to be such a core partner. Even though you're gone, you're not.
I'm coming back as often as I can. Danny, it's great to see you. You're looking great, and great to hear about that vision and strategy for the Mailman Center. I think that's right in line with where we are and what what families in the neighborhood need. Oh, and I omitted. I want to bring Jeff back into this because you know he and I have been batting this back and forth. So here's the challenge he offered us. He said, you know, the families that we see, we often, this is more of a primary care perspective. We often tell them, you know, go connect with speech therapy, occupational therapy, work on getting, you know, such a communication device. And it's almost, we're throwing them out into this wilderness. And if you ask us as primary care providers where to get that, we don't know. The family calls up their insurer, or even follows up on some of the paperwork that we've had. You know, we try to get a paper together with numbers, and they meet brick walls, that they're not able to access those services. So the challenge to our students this quarter is to develop a system that helps families navigate to those needed services. And so the hard part about this, I'm just going to offer you a design challenge here, and to imagine this, is that when you hear that, everybody thinks, oh, it's a better website for your phone, right? Or a better platform, an app, right? That connects. And the students will start to do that at the beginning. But what's really necessary is the mapping exercise that they're going to be doing. So they're going to be listening not just to parents and providers, but to physical therapists and health insurance providers. So as you do, you know, you have to map out it. There are usually 12 different stakeholders. And we're using systems designs, that the things that people have used to develop Marriott hotels and three-star Michelin rated restaurants, which I haven't gone to yet. Danny, if you want to take me there when we go, that'd be great. But we're going to be providing sort of that hospitality, that high-end system design for kids on Medicaid, and I think that's the sort of work that we need to be doing, and so that's what we're challenging the students to do.
I think Lee, I think just to follow that, I think one of the things that also is important is it's one thing to be able to address the children in our country with Medicaid, but to think about that model and how we apply that to other developing countries on a global level, where, you know, within the country there may be one neurologist, two speech therapists, and one psychologist. And so being able to think about mapping that out globally is also one of our real challenges.
Yeah, and I'll add that there are a couple of questions coming in, but Danny, I also often cite this. So along with some of the people on this call, I did go to Haiti after the earthquake. Feels like it was yesterday, more than 10 years ago. And it's in resource poor settings, particularly at times of stress, that the most innovative ideas come out. I can talk about some of the ones I witnessed. There are people on this call who can talk about more. Danny, it's actually resource poor settings, not resource rich settings like Silicon Valley and Stanford, where some of these emerge. Right. There's some questions that have come in from others. So Robert Pfeiffer says, there's emerging research area in adults on the impact of loneliness on health. Have you uncovered this factor either as a contributing element or a byproduct of inequity? Absolutely. You know, certainly it's something that our Surgeon General has pointed out as one of the chief public health emergencies of our time, that was exacerbated by the lockdowns associated with the pandemic. We certainly find that there are different ways of defining loneliness. You know, there's sort of the external way of social support, geographic isolation, physical isolation. But what seems to be most powerful in this equation is more of the internalized sense of loneliness and isolation. And we pick that up remarkably in the parents and providers of care to children with special healthcare needs, and particularly that subset of children with medical complexity. It's really popping out. We think it's a main mechanism why those parents, adjusting for all the other factors, including geography, have a significantly lower life expectancy than their peers. And we think that sort of internalized loneliness is a big part of that. Other questions. Jairo says, I know adults in the autism community who may be interested in participating in a project like this if we reach out to them. Thanks for pointing that out. Yeah, you know, and this even comes into the classroom. They say, well, do we have to work just on kids? You know, we need to remember in pediatrics that we're part of a life course perspective. And that we need to be involving, you know, and particularly this is Disability Awareness Month, right? So we need to be involving certainly adults with disabilities and our children as they transition.
Lee, good to see you.
See you. Oh, yes.
Hi.
Hi, Ruby. Good to see you too. Question?
Good. No question. I just want to update you and we can talk offline, just so you know that the Jumpstart program
Yep.
has developed now into an app, Jumpstart on the go. And yes, exciting. And it has an AI component with the human, kind of touch with the consultant. So I definitely want to talk to you about that. And we're doing
I
some
needed to
looking
show up
for.
for this to know we
You
will talk.
did.
That is
Yes,
great.
I'm gonna reach out
That
to
is
you.
so great to hear. Yeah, wonderful. Thank you, Ruby. You're amazing what you do. We need to regroup on that. Any other
Hi,
questions?
Lee. I had a question. It's
Go ahead.
Valerie.
Hi, Valerie.
How
Great
are
to see you.
you? Great to see you. Um, the question is, speaking of, you mentioned resource poor areas. So I was just curious, resource poor likely often equals technology poor.
Mhm.
And so how do you envision addressing that? Even within the states, there are parts of the country in the South,
Yeah.
the deep South, where my family's from.
Yeah.
And even here within, like North Miami, some of the, the families there who share a cell phone in a
Yeah.
family, kind of thing. So there's also limited technology literacy. I
Yeah.
mean, all of these other things. I'm just curious
Link.
how that
It's link. Yeah, we call it tech equity, techwity, some people are saying.
exactly.
Yeah.
Yeah, exactly.
So and I hear what you're saying. So I would love to hear your answers to this and other people's answers. I don't have the answers. I'll tell you a couple of things that I'm thinking about for. So first, while you're right that there are obviously in resource poor settings and communities and families, less technology access, that has changed remarkably. And in some ways, for those of us who are older, right, more than we may have imagined even 20 years ago. So that, still, at least in the US, more than 90% of families report having a smartphone in their family. Like you say, it's not necessarily on their person. So that's one piece. And so we still think we can leverage that. It's not that it's technology absent. It's just that maybe it's not all there. What we also do know, to your point, is that they're very reliant on cell phones and not landlines and not Wi-Fi to get that access, which is often slower, right? Less reliable and costlier. So here's my thought, and I haven't really pushed this with the Medicaid managed care companies yet, but I'd love to get a really progressive person helping me think through this. And I might not be the only one. But when you think about the high needs populations having chronic illnesses, and we often prescribe for them durable medical equipment. So for those of you who aren't familiar with that, that could be, a wheelchair, it could be a communication assist device, it could be a bath chair, or whatever. I am so convinced, and I became convinced day one of the pandemic, that this, sorry, you can't see that, a smartphone is a durable medical equipment and an essential piece of equipment for those high-risk families. So we can't say give cell phones and cell phone, plans to everyone. But why don't we go after everybody on Medicaid who's got a chronic illness and make sure that the insurance companies are covering that? Because when you think about it, if there's any device that we could give them, one device across the board that would help, that's my mental model for this. But I haven't found an open ear. You got Valerie, you might know some, hot shots that run health insurance companies better than I do. But that's my thought. I haven't taken that further. What else, what other thoughts do you have? I mean, I think it's a great question.
I was just wondering it as you were mentioning the different sort of the co-design with families. I mean, I think it would be excellent. But I was thinking of if they have, if in areas, pockets, there are limited resources, it may, equal tech inequities also.
Yeah.
And how could those two meet up?
Yeah. So that
Yeah.
was one thought. And by the way, it's not just my idea. One of those cycles of the design school classes, we took on telehealth as an inequity. And so it kind of emerged there in conversations with actually my co-teacher, who's a designer. She's not a healthcare person. The other thing that emerged from that was that while we were doing this, and we forget what happened during the pandemic, you might remember for 10 or 15 years before the pandemic, we had all the informatics people saying, get your people enrolled in the patient portal. And I'm not going to talk about any particular company that happens to be very dominant, big dinosaur around us. I'll keep that name out of it. But and they kept pushing us, they're trying to get us from 20 to 25% on the patient portal. What happened during the pandemic? Well, all of a sudden you had almost everybody, 90%, including resource poor settings, doing telehealth. And how were we able to do this? It wasn't just that we were forced to do it, it was the only way to do this. And in some states in California, it was more essential than in Florida, where there were kind of more lockdowns. But that there were laws that enabled it, right? That allowed us to take, cut a few corners. Oh yeah, they told us forever you couldn't use things like Zoom. Oh yeah, well you can use Zoom during the emergency, right? You can use phones during the emergency. You can cut these corners, these things that just made practical sense to us. So the other thing is, it's not just coming up with the design idea. I think it's having that policy initiative to cement it, to say, yeah, we can do this and we have to do it. So that's where the moral policy part comes in. Okay, I'm talking too much. I'm checking the time. I think we're getting up on time. And Michelle, you have a very important announcement for people to get their CME, right?
Yes. If you're seeking CMEs, make sure you signed in with the link that was provided in the chat. And then everyone, please complete the assessment and the evaluation. And thank you, Dr. Sanders, again for your time today. And thank you everyone for joining us.
Thank you. It's been great. Take care.